My name is Blessina Kumar, and I'm with the Global Coalition of TB Activists, along with my colleagues, Archana, Priyanka, and Darren here. And we're really delighted to be doing this session because human rights and TB has been something that's been very close to our hearts. And human rights was a missing piece in the global TB response till recently. And, there was some talk about rights, but GCTA really took the first steps to move away from the rhetoric of rights and to make practical and bold move towards making rights-based response in TB a reality. GCTA, in partnership with colleagues like Brian, Alan, Northwestern University, Stop TB Partnership, has been on this journey. And last year in Hyderabad at the 50th Union Conference, we were able to have a first ever workshop that brought together the judiciary, lawyers, civil society, donors, and affected communities together on a platform to discuss what actually this meant. And, to further deliberate on what it would mean at country level to have a rights-based response. And in continuation of this, GCTA again took the lead to develop activating a human rights-based TB response, a policy brief for policymakers and national TB program implementers. Now, this brief presents a set of action guiding recommendations, and we'll hear more about this from colleagues. And this was launched globally in July by Dr. Tedros, Director General of WHO, in the presence of UN Special Rapporteur on Right to Health, Daniel Sporas, and who spoke very highly about the importance of protecting and respecting the rights of individuals. And this really has taken the TB world by storm. And we are really delighted that WHO has taken it as one of their indicators for member countries to be reporting back on. And another very encouraging move following this is that based on this, the UN Secretary General's 2020 progress report has included human rights and combating stigma and discrimination as one of the 10 top priority recommendations to achieve progress towards global TB targets. So this is actually extremely important, valuable step that communities have actually changed the landscape of policymakers and bringing realities into the policymaking arena. And we continue on this very important journey along with our partners and colleagues from across the globe to make a difference in the global TB space, to empower communities about the importance of rights. You will hear from our partner representing the Asia Coalition, Activist Coalition on TB Asia Pacific, ACT-AP, who have developed a training module and are in the process of developing a training and empowering communities to understand this better. And also, we are on this journey with partners to develop further guidelines in making sure that at the country level, people who are affected by TB, their rights are respected. And we have an amazing panel with us today, extremely passionate, extremely, with lots of rich experience in this field, who will speak from their own experience and contribute to this panel. And I would like to thank my team for putting this together. They've worked really hard day and night, and let's, without much ado, I hand over to my co-moderator, Archana, to take this forward. Thank you very much for being with us today.
Thank you, Blessy. Good evening from India. Hello to all. A warm welcome. It's my pleasure to be moderating this session along with Blessy. And as Blessy said, like this session is a continuation of what we have been doing in order to transform the TV response to be equitable, people-centered, and rights-based. So we have an interesting list of speakers among with us who has been through with us in this journey. So we have Professor Bryant Alan. Apologies if I'm mispronouncing your name. Priyam, Neokabi, Jeffrey, and Ani. So all these people have been with us through this journey, and they were all with us in the workshop which we held it last year. The workshop was, as Bessie said, was a big success in the way that we had the legal community and the community TB affected people coming together. And at the end of the workshop, what we did was we had a action plans, what is really required as an action. It's something taking in forward the global commitments and the Nairobi strategy. So we have a clear action plan for what is needed to be done at the country level and at the regional level. So this session is actually a follow-up of the session which we had last year, and this is in continuation. So our first speaker I would like to invite is Brian. Professor Brian is the main author of, because main is a very dear colleague of ours, which has been through with us in this journey. So he was the main person who with whom we worked together to design the workshop last year. And after and as an outcome of the workshop, we had, as Blessy said, which was launched on 21st July, the policy brief. So Professor Brian will be explaining to us, or will be taking us through the journey about the policy brief. Over to you, Brian. Thank you.
Thank you, Archana. Hi, everyone. Welcome, or not welcome, but greetings from Chicago. It's early here. I'm really grateful to be a part of this. If there's a little sound in the background, I apologize. It's the heat because it's cold here, and it will stop soon. There we go. So, as both Blessy and Archana said, I'm here representing Northwestern University School of Law. I'm also a human rights lawyer and an independent researcher. And I've been fortunate, very fortunate to work with Blessy and Archana and the Global Coalition of TB Activists often. And over the last year, in particular, as Blessy said, starting at the last union conference, we held a workshop as a side event where we had lawyers and people affected by TB from, I think, 8 or 9 countries in Asia and Africa. It was a training on human rights, in essence, and also coalition building between lawyers and activists. That then led to this policy brief, which is in some ways the basis, or at least the jumping point for this session. So I worked closely with Blessy and Archana to develop and write this policy brief. So what I want to do in the next few minutes is kind of talk about it a little bit, explain what it is, how it came to be, and then what's inside of it. Because what's inside of it is, in many ways, the content of a rights-based approach. And as Blessy said, something that we've both taken to saying, because I think it's a nice way to put it, we're trying to move from the rhetoric to the reality of rights. And so to do that, we need some meat to the bones of what it is, of what a rights-based approach to TB is. So that's what I'll try to do in the next 5 minutes or so. So importantly, this brief, we call it a technical brief or a policy brief because it's written for policymakers and program implementers. So it's called Activating a Human Rights-Based Approach to TB, a technical brief for policymakers and program implementers. So the idea is we're speaking directly to folks who are running NTPs and people who are making policies or legislation, and telling them, here are the ways, one, that you can implement a rights-based approach. 2, we're telling them what is a rights-based approach. And then 3, we're giving the evidence. And so the methodology of how this brief was written, I'm not sure if we've passed it around yet, but it should be available to everybody. I'm sure Blessy can make it available. It's free, available online as a PDF. So what we did was extensive desk research, where we also conducted interviews with 6 people, so 2 prominent TB doctors in South Africa and 1 based in the United States, and then 4 people affected by TB in India and South Africa. People with very different experiences, but all 4 people with deep knowledge of what it means to have TB and what it means to face the challenges of having TB. And so from the doctors, the people affected by TB, and then our collective experience, and then hours and hours of research. That's how we wrote this document, Activating a Rights-Based Approach to Tuberculosis. And so what I'll do then is just give you a sense of what's inside of it. As I said, I hope this will help start the conversation today. So what we decided to do was focus on 5 human rights. So there are a lot of human rights, obviously. There are more than 5 that are relevant for TB, but we wanted to be concise and clear. So the 5 rights that we chose to focus on are the right to health, the right to be free from discrimination, the right to privacy, the right to information, and the right to liberty. So the idea is that each of these rights has something unique to offer in terms of how we should respond to TB. So for every single right, for all 5 rights, what we do is we explain what it means. We say where it's at. So each of these rights is legally enshrined. So it's actually law at the international level, at regional levels, and then in constitutions all over the world. So that's an important thing, is that when we're talking about a rights-based approach, we're not making new things up. We're not pulling things out of the air. These are things that exist. And every day courts and lawyers and policymakers deal with. What we're saying is these things play a role, and they should play a larger role in the TB response. And the idea is that it supports and enhances public health efforts and clinical work. So we're not trying to supplant public health measures or people doing good clinical work. We're saying a rights-based approach is a necessary part of that. And here is a way to understand that. So the other thing we do for each right is not only explain what it means, but I think this is important for policymakers and program implementers. We give extensive evidence. So Blessy will laugh when I remind her that there's over 200 footnotes in the document, which is maybe very academic. But the idea is, if we say something like discrimination stops people from accessing treatment, where's the evidence? Right? If I'm a policymaker, if I'm running a program, I'm used to operating based on clinical evidence or even public health evidence, studies that show how and why certain things work. And so what we did is we gathered all the evidence, mostly from public health and biomedical studies, and showed how it supports a rights-based approach. And so I think that's really important for the audience of this document, but just for everyone to understand why we're saying this stuff is important. So in the 2 or 3 minutes that I have left, what I want to do is give some examples of the recommendations, because the real meat of this document is the recommendations. That's taking the content or the explanation of the rights. It's taking the evidence that support why the rights are important, and then it's saying, okay, here's what then you should do, manager of the NTP, policymaker in the Ministry of Health, et cetera. So that's what I want to focus on in the last few minutes. So for the right to health, each right has about 5 or 6 recommendations. For the right to health, we were actually asking governments or ministries of health to create TB technologies task forces. So why? Because anyone who's paying even marginally attention knows that things are changing so quickly and rapidly in terms of technologies that are available for prevention, which is the theme of this conference, for diagnosis, and also for treatment. That's a good thing. They should be changing more quickly. We should have more. But over the last 3 or 4 years, things have rapidly moved forward. So we think that every government should be on top of those advances and be prepared both financially and from a technical implementation standpoint to quickly take new technologies and implement them. Why is that about the right to health? Because the right to health creates a right for people with TB to have access to those technologies. And they can only get access if their governments are prepared to do that. to bring those things into the program. We also talk about eliminating intellectual property barriers. So another part of it's kind of where we have the luxury of being in a position where we have intellectual property, which means patents, because we have new things. But when we have a new technology, if it's on patent, it means that it's expensive, generally speaking. So how do we ensure that patents don't get in the way of accessing drugs, preventative or treatment drugs, and diagnostics? So that's for the right to health. For the right to be free from discrimination, you may or may not be surprised that almost no country in the world actually prohibits discrimination against TB, or people with TB rather. So if I am a school teacher in Nigeria or India, just by example, but many other places, and I get TB, I'm home taking treatment, or then I'm no longer contagious, or even I've been cured, I may still be fired, let go, dismissed, and there's no law that protects against that, generally speaking. So some of these things are quite obvious, but need to be said anyway. So we're saying you should create policies and implement them that prohibit discrimination based on TB. Don't discriminate against people with TB. That doesn't help the response, and it's unfair and hurtful to people with TB. So similarly, you may be surprised, or you may not, that there really is no protection for privacy or confidentiality, not in law or policy, at least, for people with TB. So what we're calling for is there to be policies or laws that establish a right to privacy and confidentiality for people who have TB or who are affected by TB, their family members and TB survivors, etc. Why is that important? Well, no one should have a right to know anything about me that doesn't affect them. So if I'm no longer contagious, or if I'm not a survivor, nobody should know I have TB. But most importantly, stigma and discrimination follow TB, unfortunately. So without privacy and confidentiality, people are harmed by stigma and discrimination. And so is the response, because stigma and discrimination discourage people from getting tested and treated in the first place. I'm going to quickly close up on the last two rights. The right to information, we talk about the need for counselors and peer-to-peer counselors, but also social professional counselors, and also training healthcare workers to have the right information to give people with TB, to let them know that you can be cured, what are the medicines, what are the risks and benefits, treatment literacy. So that's the right to information. And lastly, the right to liberty, like discrimination and privacy. You may be surprised to know there are hardly any laws or policies that say when you can and when you can't deprive someone of their liberty, meaning isolate them involuntarily. So we are asking for there to be a policy that clearly draws a line based on the WHO ethics guidance, actually, about when you can voluntarily isolate someone. And it turns out there are very narrow circumstances. So I think I've gone over my time, but in essence, the policy brief is written to try and influence policy and how programs are operated. And I'm excited to hear what everyone else has to say here in this session. And I thank the GCTA for including me.
Thank you so much, Brian. Thank you for taking us quickly through the policy brief in a very short time. I have shared the link to the brief in the chat box also. And we are also pleased to share with all of you that our journey or our work doesn't end here. We are already in the process of making sure that it is implemented at the country level. We are working with partners at the global level to make the brief available in various languages. We're already in the process of being translated into Bahasa, Spanish, French, and such. So it's like more things are coming up out of it. Thank you so much. Our next speaker is Alain Melache. I mean, Alain doesn't need, I think all of us working in TB response knows who Alain is. He is a very dynamic leader in the field of human rights. Like we all know what he has done to ensure that rights-based approach is related to HIV as well as. Alan is executive director of Kenya Legal and Ethical Issues Network of HIV and AIDS, shortly known as KELINT. And most interestingly, what I would like to say that is he is also currently representing 7 Kenyans who are challenging the manner in which the quarantine process has been rolled out in Kenya during the COVID time. Over to you, Alan will share to us about the challenges and opportunities in implementing a rights-based approach to TB at country level. Well, thanks.
Great, thank you very much. And I'll pick up from where Brian has left and just say that there are a number of challenges and opportunities that are available to us at country level in terms of trying to promote a rights-based approach, but also as we try to do so, the opportunities we may come across. So in the next 5 minutes that I have, I'll try to speak through those particular challenges and those particular opportunities that exist. I want to start off from where Brian left off and say that there's a lot of information available courtesy of the work that has been done by GCTA, TB People, Stop TB Partnership, Global Fund, and many other players who have been able to put together a number of publications that are extremely useful to inform the rights-based approach. Of course, the publication that comes to mind for me is a publication around the Nairobi Strategy on Tuberculosis and Human Rights. That is one publication that began most of the work that we began taking forward around what is a rights-based approach. And then consequently, we had publications such as legal, environmental, and gender assessments that the Stop TB Partnership has supported in a number of countries. And I see some participants who are from those countries. We consequently had a declaration of the rights of people affected by tuberculosis, which I know TB People has played a big role in terms of being able to take forward in different languages and in different regions. And the Global Fund to fight HIV, tuberculosis, and malaria had a number of information notes on TB and human rights that are equally useful in terms of taking that forward. So I want to begin by saying that there's a number and a lot of information available. What we need to do is to understand how then does the rights-based approach work and how can we use some of this information. We all appreciate that, as Brian has rightfully said, the rights-based approach basically means that you're upholding the rights of the people who are affected by TB, and mostly some of the rights that are most problematic include the right to life, to health, non-discrimination, privacy, informed consent, housing, food, and water. And in doing so, you're trying to look at a person from a holistic perspective. Do they have food? Do they have water? Are you addressing stigma? Are you addressing discrimination? Are you reminding government what their legal obligations are? And what are you doing in terms of using the legal and policy framework to create a more enabling legal environment for people to have more affordable medicines, more efficacious medicines, better diagnostic tools? So that is what we all aspire when we are looking at taking forward a rights-based approach. Now, in order to keep this approach alive, we need to lock onto some of the opportunities that are currently available in country. The first opportunity that applies to every individual who stays in a country that is supported by the Global Fund is that the Global Fund is currently going through a process of developing funding requests for the next 3 years. And in those requests, there's an obligation to ensure human rights programs are included and are funded within the money that is given both for government and civil society. So I think one opportunity that exists is we need to go back, figure out at what stage of funding request is your country at, and can you be able to influence some of the activities that are available in the documents that I talked about to be able to ensure that we have a rights-based approach going on. Equally, in the same countries are rushing to finish the money from the grant that is ending this year. It provides an opportunity for reprogramming. It provides an opportunity to push for human rights activities that could have been done but were not done because other priorities were then put into place. I think going forward to the fact that the UN General Assembly is having a conversation about issues of TB and where we've reached with targets, I think this provides another opportunity for us to be able to engage with our ministries of health, with our ministries of labor, with the ministries dealing with information, to be able to advocate around the issue of where are we with the targets, how much investments have we made around the right to health. And then the last opportunity is there are a number of countries, and they're available on the Stop TB website, who have already conducted legal environmental assessment, gender assessments, and key population assessments to see what are the legal barriers, what needs to be done, and what needs to be addressed. If your country falls into one of them, taking forward some of those recommendations with support of partners such as USAID is an opportunity that arises. However, we must be alive to the fact that it's a very challenging operating environment people are working in now. We are seeing authoritarian governments that are not receptive to the empowerment of communities and people being held accountable. And so even though the Global Fund may say, Stop TB may say, publications may say, you may be dealing with a government that is pushing back on the issues. We've seen reduced funding towards advocacy activities and movement building for communities and civil society organizations. That again has hampered the ability to be able to move forward the conversation. And there's increased focus on COVID-19, especially from a medicalization perspective, that is now pushing us away from the efforts we'd already made to make the response to infectious diseases such as TB a people-centered approach, and people are going back to the medical response, which is not helpful. So as I conclude, I just want to say, as we go forward, we need to push and grab the little funding that's available from the various partners, including Global Fund, including USAID, to see how can we get some of those funding to be able to support grassroots-based organizations, to advocate and mobilize and hold their local leaders accountable. How do we ensure that the affected communities, those affected by TB, are engaging in these Global Fund processes, and they're being able to ensure that the allocation for interventions, for human rights, capacity building, and actual legal representation? And how do we continue to share these tools that people would be able to make use of? There's great momentum and opportunity to ensure that the rights happen, but it calls upon us to look at the situation at hand in our countries and try to use the resources available and the opportunities to network with other colleagues to take this forward. I'll stop there, looking forward to the question and answer discussion. Over to you, Chana.
Thank you, Alan. Thank you for sharing with us the opportunity which is available. As you say, like there's little opportunity available, but we need to do with whatever we have to transform all the global commitments and the policy brief actually at the ground. Yeah. We'll take all the questions at the end. So I kindly request everyone to please put the questions in the Q&A, as we will take up all the questions later at the after all the speakers have given their presentation. Our next speaker is Priyam. Priyam is a Delhi-based lawyer, and many of us know that Priyam has been working closely with the patient community in demanding an environment for sustained accessibility and affordability of all the medicines and treatment in India. Priyam is was also one of the legal professional lawyer who participated in the workshop last year with us. Over to you now, Priyam. Thank you.
Hello, everyone. Thanks, Archana. I'm supposed to be speaking about the role of the legal community in advancing the needs of those whose rights have been violated. I will just share my screen so that, 1 second.
Sure. Sorry. Or do you want us to share it for you, Priyam?
Is this visible?
Yeah, it's coming. Yeah, we can see. Yeah.
Great. Yeah. So I'll just give a repeat of what Alan and Brian have been talking about, even from the brief, that right to health, which is recognized as the highest attainable standard of physical and mental health, obligates the state to respect, protect, fulfill, and progressively realize the rights of everyone to health. And this actually helps legally enforce these rights before an adjudicatory body, and in manners where there is discrimination, that is inequality, lack of information, education, or counseling on what kind of treatment and care will be available to the patient, if the privacy or confidentiality of the patients are violated, or informed consent from the patients are not taken. And that's where we bring in the human rights approach to patients' care and treatment. In terms of legal community coming into picture, it's two steps. It's just not one way. On one hand, you have to train and have advocacy with the patient communities themselves on what are the legislations, what are their rights, what kind of policies exist, what could be used when some right is violated. Do they have to go through a lawyer? Can they approach the advocate body themselves? Or is there a separate redressal mechanism altogether? At the same time, it is also important that the legal community is also trained on what is a human right approach to health. How do you interact with patients? How do you understand what is the problem? Even in case of tuberculosis, it is important to understand the stages of how grievous the situation is. For instance, in case of DRTB, where patients might need faster access to medicines, or there is a requirement to ensure that there's no stock out of medicines at a certain stage, how to ensure that these medicines are available within a particular geography or not. And what I'm going to give examples of would be where TB community themselves have come and intervened at a legal level to ensure that their rights are protected and they get the treatment and care that they wanted. One of the cases was a group of people who work on tuberculosis got down together, worked over a year, uh, collected records and data through Right to Information Act, which is available in India, finding out how many patients get treatment, whether the dot center where the TB patients are treated by the public system are functioning well enough, the level of transparency there, whether the medicines are available or not, whether the patients are counseled or not. And they filed a petition before the High Court of Delhi seeking that the recommendations by them vis-a-vis better functioning of the dot center should be taken into account. And the court directed the government to look into the recommendations and ensure that these centers function well enough so that people are given appropriate counseling, they're given treatment and care. Then comes employment security. In terms of suing the government or seeking enforcing your rights, at least in India, it's difficult to take the private sector to the court and enforce violation of rights against them. Uh, but it's easier in case it's the state authorities that are party to this violation. And one of the ways of recognition of rights is codifying those rights. So in terms of tuberculosis, while there is no explicit legislation in India that says that these are the rights of the persons affected by tuberculosis or have lived with tuberculosis, but certain rules such as civil services rules in a state called Maharashtra specifically provided that if there is an employee who's affected by tuberculosis, they are allowed to go on long leaves. And in a particular case, there was a woman constable who was suffering with MDR TB, and while the rules allowed a limitation of 1 year of leave for people affected by TB, the court said that no, given the grievous situation, grievance that the woman was affected by MDR TB, she should be allowed a full paid leave with benefits for the 4.5 years that she was affected and struggling with TB. Another one is discrimination that we have spoken about, that treatment and care should be available to all without discrimination on an equal basis. And this is a case of an 18-year-old woman who was suffering from MDR TB. And initially, when India introduced Bedaquiline in its national TB system, it was available only in 6 cities on a pilot basis. And to avail Bedaquiline, this woman had to travel from where she was living to the capital called Delhi. And there she was denied Bedaquiline, stating that she's not domicile of Delhi. So in order to ensure that she gets or has access to Bedaquiline, because this was her last um, means of surviving, she moved the court. She challenged the policy that said that only those who are domiciles of that city and are affected by MDR TB would be given Bedaquiline. And the court agreed. The court and the state itself said, we clarify that the persons who are affected by MDR TB will not be discriminated on the basis of domicile. Anybody who needs the drug will be provided. And the lady was able to secure access to Bedaquiline. And what I want to point out here is that at different stages, it was the TB patients themselves who came forward, supported by the community and interacting, helping them interact with the lawyers to get the adequate result and treatment that they required. While we do talk about right to health in a fashion of straight or direct infringement, such as denial of treatment or discrimination in providing care, We also need to look at allied policies or legislations that would pose a barrier to access to medicines. Like Brian talked about the few recommendations provided in the brief. One of them was looking or removing IP related barriers. And in India as well, the TB community has very actively challenged the barriers that are imposed by patents on TB drugs. And they do this on the basis to ensure that secondary patents are not granted to TB drugs that might prolong the monopoly and ensure that there are better, or rather more generic companies coming in and providing affordable generic versions of the drug. An example I'd like to give is of the 3HP regimen. The 3HP regimen comprises of the known drugs, which are isoniazid and rifapentine, and used for preventive treatment of latent TB. And Sanofi had filed applications for it across the world, including in India, seeking a patent over this regimen. And the persons affected by TB filed objections before the patent office saying that these applications are not eligible for a patent, and subsequent to several other objections raised in different parts of the world, eventually these applications were withdrawn, not only in India but also in Europe and some other countries. Similarly, talking about, again, tuberculosis related medicines, we have the BPaL regimen, which is the latest regimen which is being looked at for treatment of MDR-TB. And the application related to BPaL regimen has also been challenged. Important to look at it is that it is a method of treatment. So the challenge has been based on questioning whether you can actually patent a method for treating a particular disease. And also the important fact is that development of the BPaL regimen has seen a huge amount of public investment. And therefore the TB community has challenged the patent application, stating that, first of all, the application does not cover the patent eligibility standards, and also that the public investment cannot, the public investment shows that the patent applicant, which is the TBA in this case, cannot conclusively claim the ownership over this patent. And also in terms of Bedaquiline, there have been multiple secondary applications, which if granted would prolong the monopoly over the Bedaquiline drug. So currently Bedaquiline is patented till 2023, whereas there are several other applications. For instance, an application wanting to provide patent on Bedaquiline salt, a fumarate salt. If that is also granted, then the monopoly over the Bedaquiline drug would extend up to 4 years to 2027. So these applications have also been challenged by DRTB survivors, and we are hoping that the patent office will come back affirmatively on our objections. So these steps have been because of the constant interaction of the community and the legal community. And this has been a mutual learning for both of them, because the legal community cannot operate on its own. It has to understand, like our previous speakers also mentioned, that it has to understand what the TB survivors and patients are facing. And only then we would be able to see what kind of steps and what kind of human rights approach has to be taken in combating violations of human rights. Thanks. Over to you, Archana.
Thank you, Priyam. Thank you for sharing your experiences from India. And as Priyam also rightly said, I think to transform the TB response, I think what is also important is the capacity building of the legal community as well as the community representative. And we at GCTA, we have been focusing on that also, like as from the workshop, it didn't end over there. We still have the pool of lawyers in touch with us, and we keep on sharing the resources every now and then. Our next speaker is from Nyokapi Nazogi. She will share with us her from legal perspective from her experience based at Kenya. She is an advocate of the High Court of Kenya, and she is also currently the legal counsel at Kevin, where Alan is working at. Yeah, over to you, Nyokapi. Thanks. Hello.
Sorry, Achana, I'm having a small problem unmuting myself. Could you please unmute me completely? There, sorry, I've succeeded.
Yeah.
Okay. Thank you
We
very
can
much.
hear you now. Yeah. Yes.
Yes. Okay. So I just want to briefly touch on what we lawyers can do in ensuring that patients secure their rights and have a way of enhancing their care and support. In order to save on time and not to be too repetitive, I won't go through my entire slides. So I'll just start with why should a legal response, why is it important? And one of the things that we do have to recognize is that for those who are seeking care, treatment, or support for infectious diseases such as tuberculosis, they face various challenges and infringements of rights. And this in itself is a factor that has to be taken into consideration, because that means that they would need access to justice to redress those violations. Secondly, those violations have the effect, as somebody mentioned before, of affecting access to healthcare, and they tend to entrench stigma and discrimination, which in turn defeats the public health purpose of some interventions. And this, of course, discourages health seeking. Again, research has shown us that tuberculosis occurs within a particular socioeconomic context. And as one would bluntly say, it really is a disease of the poor, seeing as it is most prevalent in crowded institutions and living spaces. In addition, people who are diagnosed with TB tend to lose their employment or have limited success in securing that employment. And generally, the cost of medication, including the distances that they have to travel in countries such as Kenya, means that they are pushed more into poverty as they try to seek medication. So a legal response is extremely important. As Priyam has mentioned before me, as they need to access, patients need to access healthcare services. So there's a legal obligation to ensure that there's access to the timely, acceptable, and affordable healthcare of appropriate quality, what we call the AAAQ framework. But in addition to just the right to health, there's also a need to ensure that the underlying determinants of health are made available to all, particularly for those who are undergoing treatment for for TB. And this means that there has to be access to food, there has to be access to water and sanitation facilities and living spaces for those who may choose to take their treatment at home. This can only be done when there's an enabling legal environment, and this is where we lawyers can come in. Now, what role can we play? So the first thing is that we need to build knowledge, as somebody has said. I agree with Priyam when she says that there is a need to build the capacity of lawyers who work in this space. And I think it was during the last workshop that we had on this very topic that the keynote speaker actually mentioned that lawyers need to learn the science, the medicine and the science behind tuberculosis. In addition, we can advocate for the protection and promotion of rights for TB patients, again, including the socioeconomic rights, which form the underlying determinants of health. It's very important to also ensure that there is training and capacity building for both the infected and the affected community, but also for decision makers and policy makers. And here I'm thinking about magistrates, I'm thinking about judges, public health officials, and members of parliament. I am aware that this has been done to some extent through multi-stakeholder dialogues. Kelly and I think Stop TB Partnership have been part of this, but there is a need to make sure that these efforts do not relent. They need to be continuous, seeing as increasingly more and more this knowledge does not necessarily trickle down to where we hope that it would. And I think we have seen that this during the COVID response. The idea behind building knowledge is that it reduces stigma, and then it leads to reductions in defaults in treatments. And then obviously this will improve treatment outcomes. Lawyers can also aid in the establishment of mechanisms to ensure that Violations and the effect of interventions are documented. Documenting these rights violations can be used in support of court action. They can also be used to persuade decision makers and policy makers about the importance of a rights-based approach. Lawyers should also be open to reporting of rights violations for patients, seeing as patients tend to be more afraid about reporting, because usually it means that it may be difficult for them to, they may be stigmatized further. And because of this fear, then of course, they may not want to report. One of the most important roles that we can play as the legal community is to ensure that legal services are available and aid patients in securing access to justice. So here I'm thinking about ensuring the availability of legal support for patients, particularly those who face discrimination or rights violations. Here at KELIN, we do receive quite a number of complaints about people who are discriminated against, and it behooves the entire legal community to get involved in this support role. Legal support should include pursuing court action. At KELIN, we have successfully used strategic litigation to compel the respect for the right to health, as well as for the underlying determinants of health. One of our successful cases in this regard was the Daniel Ngetich case, which was decided in 2016. And here the High Court of Kenya declared the practice of confinement of TB patients in prison facilities as unconstitutional. The court also required the Ministry of Health to implement an isolation policy. And this was actually done by the government through the Ministry of Health. Unfortunately, now we have come to see that it did not quite work as we had hoped that it would, but it was a first step, because now TB patients in Kenya are not confined in prison facilities for purposes of their treatment. Just a note on strategic litigation: there is need to have it be well thought out. It needs to be well planned and researched. And of course, I think it also matters a lot the kind of remedies that we seek in strategic litigation, and ensure that these lead to social and policy change for the community that we intend to serve. Learning from the Daniel Ngetich case, we've also learned that it's very important to ensure that there is a post-litigation strategy that ensures that once a court case is concluded, those decisions are continually implemented. I've mentioned that strategic litigation should lead to social and policy review, and one of the things that lawyers can continuously also do, with or without litigation, is of course advocate for the review and amendment of local public health litigation to integrate a rights-based approach. This is something that KELIN, for example, is still working towards. The idea being that these interventions need to be brought into conformity with existing international human rights standards. Again, we need to advocate for the incorporation of ethical standards associated with measures being taken to address TB treatment. Some of these need to be considered are, for example, is isolation for TB patients the only recourse to treatment? Bearing in mind the effect of TB treatment on patients, can we ethically advocate for forced treatment? Are medicines available for all, and are they accessible to all those who need them? For example, in Kenya, TB treatment tends to be very, very expensive. And that's why I talked about sometimes it may lead to driving of patients into further poverty. And not just in terms of medicine, but even where people have to go and get their medicine. Is it accessible? Does it mean that they have to miss work for a period of time? What effect does that have on their seeking treatment? Government spending towards TB is something that also needs to be critically looked at. As we have seen, where government interventions for infectious disease are done through donor funding, sometimes this is not properly accounted for. And this, of course, means that it leaves room for corruption. So it's, as lawyers, it's something that we can call the government to account, either through litigation or through just basically asking difficult questions. as to how this needs to be accounted for. The other thing is that we need to advocate for the enactment of legislation so that all interventions respect the human dignity, as well as rights, as well as the public health. As we know, legislation is a political commitment towards treatment, the prevention and control of TB. So when we agitate for the government securing commitments to a right-based approach, this also means that we need to ensure that the infected and affected communities do fully participate in each of these interventions. Finally, I'd like to talk about the protection of patients who may elect to refuse treatment. The science has shown us that treatment for TB can be quite difficult and quite long. So what happens to patients who elect not to undergo a treatment?
Hello?
Hello?
Hello, yeah, we can hear you, Nyokabi.
Yes, I'm just winding up. So
Yeah,
we need to ensure that all measures taken for persons who elect to refuse treatment are taken in the least restrictive manner possible. They have to ensure the protection of the human rights of those patients, which include privacy, confidentiality. And we must advocate for the elimination of punitive public health measures, which only serve to exacerbate stigma and discrimination of persons with TB. Allow me to conclude there, and I'm open to take questions. Thank you, Achana, for this opportunity.
Thank you so much. I think we have now heard from two lawyers, one based in India and one based in Kenya, where they have both stressed on the importance of capacity building, and they have shared us their case study. Now it's time to hear from community and perspective on what needs to be done to achieve the right-based TB response. I'm pleased to invite our next speaker, Jeffrey Akaba, who is the program officer at Advocacy and also the coordinator of Activist Coalition on TB. And Jeff has been advocating for the rights of people living with HIV and other key populations and TB affected and other marginalized populations since 2006. And he has a lot of experience in health policy, community development, and action research. Now, the floor is yours, Jeff. Thanks.
Thank you so much, Archana, and thank you so much to GCTA for inviting Apcaso and the Activist Coalition on TB Asia Pacific to be part of this session on TB and human rights. So as you rightfully said, at this point we're moving and complementing the work of the lawyers and looking at the aspect of TB and human rights from the perspectives of TB survivors and TB-affected communities. And what I'm going to present is the TB and human rights training manual that we developed, really thinking through and piecing out around rights-based TB responses. And one of the questions that we really asked was that in understanding rights-based responses for tuberculosis, who really benefits these rights-based responses? And how do we make sure that TB survivors and TB affected communities understand what this means and that this actually responds to their needs and challenges as part of the TB affected community. And like what Brian mentioned earlier, TB really does follow, stigma does follow tuberculosis. And in fact, it hinders people from seeking TB healthcare. We don't unfortunately have any global data on TB-related stigma. There has been stigma assessments that has been conducted, but globally we don't have a comprehensive data on TB-related stigma. In fact, the World Health Organization's latest global TB report only mentions stigma and discrimination 6 and 5 times respectively, without really unpacking and understanding the context of stigma and discrimination around tuberculosis. But we do know from the experience and from the interviews that we do with our peers that people with TB and TB survivors really tend to accept the situation as the status quo and trying to understand that undergoing treatment and experiencing the side effects is just a part, and also the suffering that they experience is just a part a regular part of how TB treatment is being provided, and not really questioning what the doctors and healthcare providers are doing, even if in fact those aspects of the work can be interpreted as an act of discrimination or a human rights violation. And when TB is stigmatized, so as people with tuberculosis, in one of the assessments that was done in the Philippines, one of the participants said that when they applied and they disclosed their TB status, the company knew, but the problem is that because they found out about their TB status, they did not accept them eventually. So that really has affected his confidence and his aspirations to have work and have employment. And in one of the pre-test surveys that we did as part of the ongoing trainings that we do on TB and human rights, 1 in 10 participants actually said that a person with TB can actually be fired from work. So as a response to the issue of stigma and the lack of understanding on human rights principles in the context of TB, we developed the Right to Breathe manual, which is a human rights training for people with and affected by tuberculosis. So this really aims to strengthen the capacity of TB survivors, those who are undergoing treatment, and TB-affected communities in understanding human rights principles and how human rights principles can be used in several aspects of the human rights work. And that includes sessions on human rights violation documentation, and also advocacy planning, and even pitching speeches to legislators, lawmakers, and even national TB program managers. And within, and as part of this training, we even do provide some exercises to make sure that we move away from some of the politically incorrect terms. For example, moving away from TB patients or the use of TB patients to people with tuberculosis or TB survivors. And those kinds of terminologies are things that we also address through this manual. And this manual also contains 6 sessions. So apart from the TB orientation, this also includes heavily on the human rights sessions, and also the relationship between human rights and tuberculosis. I just wanted to show you, based on the experience of those who already participated in the training, we were fortunate with the support of the Stop TB Partnership to have piloted this in the Philippines and also in Cambodia. And in the Philippines, one of the experience was that it was clearly related to the larger experience of the community, and through the trainings, they were able to understand human rights and how to make sure that they can make people accountable for the human rights violations that they experience. One of the sessions that we actually do as part of the training is to tease out the difference between an act of discrimination and human rights violation, something that participants really appreciate during the entire course of the training. The other experience that was shared to us based on the recent training of trainers that we did was the advocacy orientation, because we really wanted to go through each of the different steps of human rights advocacy. So we facilitate and we lead the participants through the advocacy orientation and make it tangible for them and impact, so that they are able to use the principles in the advocacy work after the training. So right now, what we are doing under the Challenge Facility is we're conducting 2 training of trainers, regional training of trainers that we're doing virtually. And so far, we have had 14 civil society organizations and key population organizations from 9 countries in Asia and the Pacific. And we are already in our second run, which is focusing on South Asia. And we're doing it for the next 2 weeks. But after that, we are also doing and supporting civil society organizations in conducting country rollouts. And we're focusing in 3 countries, Nepal, Papua New Guinea, and Vietnam. And this will complement the work that they are doing around building the TB-affected community in these respective countries. So really centering human rights principles and making human rights the center of the community engagement and the community mobilization in these three countries would be something that we really look forward to. And we also will be working in partnership with some of the challenge facility grantees in the region. In fact, one of the participants from the South Asia Run already committed to translate the human rights training manual in their respective language so that even at the local level, they will be able to roll out some of the activities. From APCASO and from the Activist Coalition on TB, the idea really is to, after training, after conducting the training among TB survivors and TB affected communities, that this will feed along with the Declaration of Rights for people affected by TB and also the policy brief that was shared earlier to develop an Asia-Pacific human rights agenda and roadmap. Looking at the policy brief earlier, there were some suggestions already on how to take the necessary steps in developing human rights-based response. But what we're going to do is making sure that at least for the three countries, Vietnam, Papua New Guinea, and Nepal, and also including some of the countries in Asia and the Pacific, we will be able to support more of a regional role in developing a regional roadmap so that we can concretely see what a human rights-based TB response would look like for the region and how do we actually get there. And we will be developing this beginning 2021. So highlighting just some of the key lessons, learning in terms of the development of the training manual and also the rollout that we're doing, is that human rights principles, when we talk about these principles, it really has to be relatable to people with TB survivors and TB-affected communities. Many people who are undergoing treatment are already saying, we don't really need to learn about human rights. We are already sick and infected by tuberculosis. Why do we need to learn about human rights? But according to some of the participants who underwent the training, they were able to understand that, oh, some of the procedures that were being done to them are actually human rights violations. And they really appreciated the fact that this training is something that contributes into the broader work that we're doing around TB and human rights. There are already ongoing assessments that are being done, but these are only entry points, and we really need to unpack this, given that in the Political Declaration on TB, there are two specific provisions, Provision 18 and 33, that really calls on to make sure that there are that socio-cultural barriers are addressed, looking at human rights-based responses. I know it's a lot of word, but we really have to unpack that. And also making sure that countries implement human rights-based responses. Again, another very sound-bitey term, but again, we really need to unpack this. And the assessments that are being done is something that that can really help unpack this at the country level. But last and not the least, long-term support to human rights responses for TB is very, very important. Looking at what the training manual offers, the human rights violation documentation, access to justice, and advocacy, these are aspects and initiatives around the human rights response for TB that really needs not only one-off support, but really long-term support as well. So the training is just one-off thing, but that is the start of an entire work around human rights in relation to tuberculosis. I would just like to end with some acknowledgements, particularly among ACT-AP Steering Committee, to Mara Quesada and Action for Health Initiatives, who really took the lead in developing this training manual and in piloting this virtually, and also Stop TB Partnership for the support. If you have any questions, we can have that later on. Thank you very much.
Thank you very much, Jeff. That was very good. I'm also speaking as one of the steering committee members of ACT-AP, and I'm really thrilled to hear you say that. And I just want to echo what you said about stigma and discrimination, which is again another thing that GCTA is very serious about. You were featured in one of our stigma and TB books with men, and we brought out one on women and one on children. These are conversations with people, but we really need some data on stigma to for us to really shake the more powerful people who have the ability to make a difference. So maybe this coming year would be something that we and our partners can dedicate that to. And really happy that the first training is already started and you're progressing with that. And you talked about language, which is also very, very important. We as a community cannot accept discriminatory, stigmatizing language. So thank you very much. And your last but not the least point that you made about long-term support is very important to mainstream human rights into our response, so that it's not just a side tick in the box that, we can do it for 10 months, 12 months, and then say we've done it. So thank you very much for highlighting those very important points from the side of the community. Next, I have great pleasure in inviting Ani Hernasari to join us and speak to us from her perspective in Indonesia. Ani is a MDR TB survivor. I've interacted with her for the past few years, and she started her MDR TB treatment in 2011, November, and after an arduous journey, completed it in 2013. She's also associated with POP TB, which is a national coalition of TB survivors, specifically DR TB survivors in Indonesia. She represents the MDR TB survivors on CCM and with the NTP. And she's also a member of TB Women. And currently she's completing her PhD. And, one of her roles is also as a lecturer at the University of Surabaya in Indonesia. So Ani, we are delighted to have you with us on this panel. And over to you now. Thank you.
Thank you so much, Ms. Praseena and Archana. Wait, I will share screen.
It's already there, Ani, you can start. Okay. Can you see? Priyanka has already pulled up your PPT, yeah.
Oh, okay. Yep. Oh, okay. My name is Ani, and I will present the building community capacity towards a right based on TB response in Indonesia. Next. Okay, this is the map for the spread of our organization of TB, that we already have 16 organization members spread in 12 provinces. This year we add 3 more new organization member in different 2 provinces. Next. Yes, from our meeting last year, we from the organization POP-TB have made a lot of progress. So we do a lot of discussion and negotiation to voice the right of patient. So we already have the president commitment. So at the meeting which held on July 21st and 2020 at the Merdeka Palace, in order to achieve the target of eliminating TB by 2013, the president gave 3 directions about accelerating the elimination of TB. The first is tracking aggressively to find the TB sufferer so they can hitch a ride in the search process for COVID-19. Second is the TB diagnostic and treatment service must continue, and treatment should be carried out until it is cured. And the medicine stock must also be ensured that they are available. Next. Wait, the third one, sorry. We have the effort to prevent and promote TB control must be carried out across the sector. Next, Priyanka. So from the President commitment to approve the preparation of the presidential regulation on tuberculosis. We also have a commitment too from the Ministry of Social Affairs that they would provide additional assistance fund for the TB people who were also sick with TB. The NTP of Social Protection, you say like Director General of Social Protection and Security at the Ministry of the Social Affairs will targeting as many as 90,000 TB will receive around 3 million per year rupees. It's not much, but it will be helped because this assistance does not include the enabler from the Global Fund. So wait, I just did, okay. Currently, we from the community are receiving grant funding from the Stop TB partnership also to strengthen our organization capacity and also to strengthen each individual in organization. Next. This is in many regions in Indonesia that the civil society organization are participating in the TB response, including in hospital, puskesmas in the field, and undertaking outreach at the village level. This is the willingness of the government, our government partners of both the district and the additional effort to partner and engage with civil society with the support from the Global Fund, LKNU and ICIA is like a Muslim organization, the biggest in Indonesia. They are currently active in 191 out of 514 districts. So as you can see that there are so many districts didn't cover yet with when I have a visit joint external mission that also support the Stop TB partnership. There is a story that I brought during the joint external mission last January in a province that I visit. At that time, I was representative from of the community and my living. I asked several patients who were still on the treatment and who have recovered. I asked them whether they know what kind of sickness do you have, and they all say that they have TBC. And then I continue ask them again, do they know what is TBC? And I still remember that all of them say no, because they were only told to take the medicine that was given to them for free. And without any nation, the patient didn't have, and also the patient didn't have the willingness to ask, why do they have to drink that medicine? So then I continue asking that, means that you also don't know about TB is contagious disease, and once all they say they didn't know. So it's like our problem because Indonesia is archipelago island, so sometimes we have difficulty to reach the outside the Java. Java is like the central island for all. Next. Okay. So this is what a community do to tackle a human rights issue. So we also supervise the service that had been provided by the government. And we also have capacity building to improve our ability about what human rights are and how we fight for them. Because, we are a new organization and because of the majority of us are blind about what is the law. And we also provide an assistance and advocacy to patients who experience with drug side effect. It's like, for example, the side effect on drug is on hearing when then makes the patient is deaf. So we from the community organization try to get the patient to get the hearing aid for free. We also providing the patient uh, during the treatment that have not received the enabler from the global fund, which is also that's their right. So we take them to the health facility, and we also provide advocacy to patients who experience. Uh, sorry, this is the same with the above the. We also assist and advocacy to patients who during the treatment. Oh, sorry, this is a typo too. We also providing shelter. So sometimes the patient who live far away from the health facility, uh, they before they start the treatment, it takes a long time to go back and forth to hospital to check their health condition like blood pressure, whether they have a diabetic or no, or other comorbidities. So where they home are far away, they can use this shelter. We also assistant for patient gathering. So this to explore the problem between the patient, or maybe the patient can freely talk about anything, their complaint, and share information. And here we can also emphasize that can talk to the survivor that who already recover and how we can empower again. That is enough for me. Archana, I give it to you. Mom Bessie or Archana. Thank you.
Thank you very much, Ani, for that, for bringing the Indonesian perspective. And I know Indonesia is made up of so many tiny, tiny islands, and it's very difficult to reach. But having supported Indonesia from way back in 2014, 2015, in training the civil society and the affected community, we as GCT are really proud to see the patient groups that have come together, especially at Jakarta. PETA is there, and at the national level, POC-TB is there, and we really, journeyed with you in establishing this, and we are very grateful. Of course, we couldn't give finance or funding, but what we were able to do is build capacity of people affected by TB, and we're very happy to see that this has happened, and we will continue to support you in any way possible. And we are really delighted also to hear about the high level commitment of what your president has actually committed to for TB. So I think with India and Indonesia being the highest burden countries,
Yes.
and also being in one region, I think we have a lot of work to do in ending TB. So thank you very much for being on that. We have a lot of questions. That brings us to the end of our panelists sharing. But we have questions which most of them have been answered very kindly by our expert panelists and the lawyers. Thank you, Brian, Alan, and Priyam for answering those questions. But there are 3 questions that are left. I'm not sure if this question about, there's a question from Amrita from India, which says when people wear, I think that is answered. Sorry, I see that now. So there's only one question now, which says some patients have spent a long time before they get the right diagnosis. We frequently hear of patients having had symptoms for 6 months or longer and having gone through several wrong and ineffective cures of antibiotics before the TB test is actually done. This is clearly a violation of their right to health, and it could point to a low capacity and or competence on TB among doctors and health workers, even in countries which have a huge TB burden. Would legal action be possible at all in such cases? If yes, would it be more relevant on local level or on national level towards the Ministry of Health, NTPs, Ministry of Education, etc., if they are responsible for the education of medical doctors and nurses? I'm not sure which country Silje Handeland is from, but I would turn to either Brian or Alan to answer this question, please.
Blessy, I can start, but my video has been stopped. I can just speak in the meantime.
Okay, no problem. Go ahead.
So I think it'd be better for Alan or Priyam to answer this, since they're in court more than I am. But
I think we just lost Brian. Alan, do you mind coming in?
Well, I was hoping Priyam would go first. I'm still trying to see what's the most good answer to give. Priyam, would you want to go first and then I build up?
Oh, I see Brian back.
Yeah, I'll just finish what I'm saying quickly. I can't start my video because the host is not giving me permission. Just very quickly that, missed diagnosis or getting started on the wrong medicines, anything that results in, having TB and probably being contagious for 6 months before you actually get diagnosed and start treatment, absolutely, probably in many ways would be a violation of the right to health and other things. So I just want to say that the premise is correct. Now, the question about what to do about it is tricky. And I think last thing I'll say is that I forget who asked the question, but you started to answer it in your own question when you asked, would going to the clinic be the best thing? Going to the local administrator, going to the national level? So I think those are the questions you should be asking. And those are the things that Alan and Priyam are very good at deciding in their countries, and maybe they can jump in.
Alan or Priyam, do you want to add anything to that?
Okay, I'll give it a shot. So, like Brian said, it's slightly tricky because there are certain standards to decide whether the diagnosis was incorrect at a particular stage. So scientifically, the doctor can always say that I have to figure out XYZ, and only thereafter I can conclusively say that this is TB or not. But when we are trying to show that there has been a certain malpractice or mistake on the part of the medical professional, in India, mostly it's under the Consumer Protection Act that we go towards for malpractice. There have been instances where, say, for instance, we do move the court saying that this is incorrect, but that is mostly to seek damages and compensation. But so it depends on what kind of relief you seek, whether you want damages or compensation for the wrong that has been done to you, whether you want the medical professional to be suspended, that will be another authority altogether. So that's another process that we need to engage with on what kind of remedy we are seeking, whether we want to revamp the system, whether it is a personal remedy that the patient is looking for. Thanks.
I'll only quickly add and say that I think Brian and Priya are quite correct, but I think also what's critical in terms of what Brian was referring to, going to different levels of the clinic, is that helps you gather documentation, and where an injury has happened to someone, say the diagnosis has given you a side effect, then you'd have to consider what Priya must say, depending on your country context, a suit on negligence or malpractice, or a context of human rights violation. But the key thing is to question, to document, and to build the evidence to be able to demonstrate that someone did not do what they were rightfully supposed to do at that time. Over.
Thank you, Alan. Are there any other questions from participants? I think there are two comments from attendees here. One says, so true, vertical programming is a barrier to information and resource allocation. And then we have a comment from Mara, says, and also explore whether we do need something overarching, standards that need to be articulated in laws and policies. I think those are very good comments from the participants. If there are no other questions, what I would like to very, very quickly do is I'm not even going to try and sum the whole thing up, but just highlight something for us to take back, and also look at what we can do next steps, because we still have 5 minutes before the end of the session. So one thing that we all understood from this panel and also from our experience is that human rights work, and especially human rights around TB, is not going to be an easy job. It's going to be difficult because we need to raise difficult issues and questions. Also around a disease that has really been neglected over the decades, a century now. And we're also, holding people accountable. And in a way, it's inverting that power dynamics is not going to be easy at all. But the fact that we have this amazing panel here that spoke about human rights, and we had over at the early part of the panel discussion, we had about 80 participants, really shows that we are committed to human rights. So that's a good start. So working in human rights really needs a well-planned strategy, a sound understanding of the legal environment in countries. We know that Stop TB Partnership has done the legal environment assessments, but it is, in some countries it's been successful, some countries it hasn't been. So again, this is a place where perhaps the communities need to lead, kind of looking at what the legal environment is like, what the TB response is like, through perhaps community-led observatories, where we assess the service delivery and the legal environment. And one of the points that all the lawyers, both Nyokabi, Priyam, and also our experts, Brian and Alan, mentioned was that we need to work together. We have worked separately, the affected communities, civil societies, and the legal community, but to achieve success for the sake of people who are affected, we need to come together. And that's why this whole thing started last year. And how can we learn from each other? How can we teach each other? How can we support each other would be a very big question. So in this coming year, from now till the end of next year, what we as a coalition would be focusing on is exactly this. In a few countries, how can we do this working together in an organic, more sort of established manner, with conversations with people affected, the communities, looking at what the needs are, and then bringing the legal community from their own countries to support them and establish. And the modus operandi for us in GCTA is that we go, we set up, we help, and then we move back. It doesn't have to be called GCTA. It is, we've seen that happen with our regional networks. We would, sort of be very happy to just initiate support and let it take off at country level. So we look forward to all of you working together with us on this. Thank you very much for being with us on this very, very interesting webinar. For all those who joined, and of course for our panelists, we will continue working together with you. And I'm going to say a big thank you to each one of you. But if you have any last parting words, I would like all of you to take half a minute before we end this. Thank you.
I'll just say quickly, thanks to GCTA and to everyone else around the world. I think you're right, Blessy, that the fact that there's 80 people on this meeting and the fact that it's on Zoom and we're all over the world and we're not in Spain is a good indication that there is a lot of appetite and interest in what we talked about human rights and TB. And so we do now have to harness that and try and make some real change with the partners here and elsewhere. So thank you.
I equally say thanks to being invited to the union for hosting this session, for the people who put it together. And indeed, as we always say, the struggle continues. It's not going to come easy. We must keep pushing and fighting to ensure human rights is incorporated in the TB response. Thank you and good day to everyone.
Jeff?
I just wanted to say thank you to GCTA and to the Union Community Connect for this session. One of the main takeaways for me would be that in building human rights-based TB response, it's really about creating an ecosystem, not only in terms of understanding the legal rights, but also making sure that people have access to justice, access to accountability mechanisms, and even education, human rights education for people with TB and TB survivors. So it's not just about one one-step initiative. It's really building an entire structure and entire architecture, not only at the country level, but also globally. Thank you.
That's it. Nyokabi?
Thank you, Blessy. There's quite a bit of noise on my part. Just to say thank you for the opportunity to present. This is my second year interacting with GCTA, and it has been a fruitful engagement. Just to say also that the work ahead is still quite a bit, and we've seen that even with positive court decisions, there is still need to continue to engage across the board with all the stakeholders. So thank you very much.
Thank you. Annie?
Yeah. Thank you so much, Mom Blessy, and to Archana, to GCTA that allow me to present, even my English is not fluent. I learned much here, so I hope we can meet again soon. Thank you.
Priya?
Thank you. It was great interacting with everyone, and I hope that we continue working on this. There's a lot done to build more capacity so that there is greater legal representation for the community. Thanks.